Hi, I'm Stephanie Shelton, and this is episode 29 of Conversations on Health, How We Get There. Is women's health moving backward? The Supreme Court's Dobbs decision in 2022 overturned what most women believed was settled law, the landmark 1973 Roe v. Wade decision, which established a constitutional right to an abortion. Since Dobbs, many states, especially in the South and the Midwest, have banned abortions for any reason or have tightly restricted them, leaving many women in medically dangerous conditions. Even before Dobbs, the United States had a maternal death rate of more than twice, sometimes more than 3 times, other high-income countries. More women are obese than men, and that causes multiple health issues. These all suggest that after major gains, women's health may be moving backward. So I asked Dr. Michelle P. Warren to come on the podcast. She's a distinguished New York physician who specializes in both endocrinology and gynecology and has spent her lifetime focused on women's health issues. In 1997, Dr. Warren founded and remains the medical director of the Center for Menopause, Hormonal Disorders, and Women's Health at Columbia University Medical Center, where she is the Wyeth Professor Emeritus of Obstetrics, Gynecology and Medicine. And full disclosure, I have been her patient for many, many years. Michelle, thank you so much for coming on the podcast. This is really great.
Oh, it's my pleasure.
You know, I've known you for a long time, and you were in practice long before I became your patient. What do you think about the status of women's health? In the time you've been practicing, has it improved? Had it improved and come backward? What do you think?
Well, it's an interesting question because when I started in practice, we were very rudimentary. We were diagnosing pregnancy by giving rabbits an injection of woman's urine. And if the rabbit ovulated, then we knew that the woman was pregnant. So I would say that things have improved a lot. There have been changes relative to different stages in women's lives that have improved. But there's a lot of noise out there that's not totally accurate, which is a little bit of a problem. And hopefully that will change over the years, but it's taken a while.
I think you told me that there is still a basic weakness in terms of finding a doctor for women's issues, partially because of pay and partially because they just don't seem to study in the areas where you are.
Well, that's true. I'm a little bit of a maverick, and I've started my career as an internist. Then I went into endocrinology, and my chief at that time decided that I should study gynecology because there was a lot of work on women that involved hormones that also involved gynecology. So I have a very wide background. And in fact, we are not really training doctors to address some of the issues that I've become very interested in, such as menstrual irregularities and menopause in particular. That has been a big void in the training of doctors. Doctors are just not getting the training, or they're not interested, or they are interested, but the reimbursement is so bad that they're not focused on it in order to make ends meet.
That's probably the issue because, you know, in many countries, if you qualify, your training as a doctor is free. In this country, you rack up student loans, you know, like to here, and then you got to pay them off and still maybe have a life because there's so many years of training.
Well, that is a big problem. I mean, I think our education is so expensive from the moment you go into college to the time you finish medical school. You can accumulate so much debt that it's you end up focusing on making a living rather than choosing what you'd really like to do. Um,
I'm gonna move on to the big story that most of us have been caring about as a woman, anyhow, as women. And that's the Dobbs Supreme Court decision against abortion. And
right.
that has changed everything that I have known in most of my adult life. And most women, most younger women, had no sense of a world where abortion wasn't legal across the country. What is your feeling about that? And where are we going? I mean, are we going? We have a solid South in a sense where women can't get an abortion for any reason whatsoever, even if it has to do with a pregnancy they want to carry to term and it's
Mhm.
medically necessary. So
Yeah.
where do we go? Where are we going?
Well, I'm old enough to remember the dark days of when abortion was illegal, and it was such a horrible time. Women were getting back alley abortions. There were women coming in with all kinds of problems, young women bleeding to death. It was absolutely horrible. I can't believe that we're going to go back to that. And so I view what's happened as very unfortunate because women who want abortions or need them are really desperate. And what's going to happen if things continue in this vein is that they're going to seek either illegal channels or go elsewhere. And only the very wealthy
Yeah.
can go elsewhere, which is a big problem. So we'll end up with a lot of indigent women in trouble. And it's heartbreaking. I can't believe that that's going to happen. And,
You're
you know,
you're more hopeful than I am.
it just, all we need are one or two cases and it'll break everybody's heart. I just think that eventually the reason will take over. Um,
Talking about reason, what if they go beyond abortion? What if they say, well, okay, no more morning after pill. We're not going to let you get the ingredients for an abortion by pill through the mail, for instance, because it's coming from a state where it's legal to a state where it's not legal. And all of those medications are used for other things, not just abortion.
right, right. Well, I think that what's going to happen is that the medical profession is going to work around those issues because I thought about the morning after pill. And actually, you can use a lot of the contraceptives that are on the market as morning after pills. You just have to be a little bit savvy. So I think that that is an issue that's going to be solved by doctors just working around that. In terms of getting medications um, by mail, that is a problem. I mean, maybe people will send uh, packages to friends in other states and go pick them up. I don't know what's going to happen, but when you're desperate, there are going to be solutions that meet that desperation. Um, but it's very sad that we have to do this in a civilized country. It seems as though we've moved backwards on that issue.
Well, if you move back on that issue, you move back on a lot of issues. In general, the United States has a higher maternal mortality rate than any other well-to-do country, and we're considered a well-to-do country. We have,
Mm,
we have more people who have enough money to live on than don't.
uh,
It's more than double the rate of most other high-income countries, and that would be mostly most of Europe, the UK, some of the Arab countries, I guess. If that's true, and again, I link it together with the abortion thing because many times, if a woman has a non-viable pregnancy, and is forced to carry it to term, that can be a death knell for her also, can't it?
yeah, I mean that could be a terrible problem. Um, but I think we have a population that's unfortunately obese.
Mm.
And obesity is a terrible risk factor in pregnancy because of it's much harder to take care of somebody who's obese. And there's a high incidence of diabetes, which is bad for the mother and the fetus. So, in addition, we have a problem amongst various groups with drug addiction.
Mm.
And if you don't show up for your appointments and you don't see a doctor during all of your pregnancy, it puts you at very high risk. Countries like France, they pay poor patients to come in for their visits. They
Really?
actually get a payment for coming in because they realize that paying these patients improves their health so dramatically and improves the health of the baby that it's worth giving them this kind of compensation. So we've got to find some other solutions to improve the maternal mortality in the United States, which is a big problem. And it's embarrassing for a country that's as evolved as ours.
Well, it's tragic. It's
Mhm.
just, um, we know that a lot of people, men and women, do not get any kind of care, either because in some rural areas there literally is nobody to give them care, and maybe they can't do telehealth because they don't have the infrastructure that they will allow them to use it. But in the cities where there are so many poor people congregated, they have access to a very good health care plan. It's probably Medicaid is as good
Mhm.
as you would get it in any country. They either
Right.
don't know about it or they don't trust it. And since pregnancy is such a huge issue to most women, you know, it would seem to me that there needs to be some kind of outreach, more so.
Yeah, well, I think there are some hospitals that are trying outreach in these poor areas to get these pregnant women in to see their doctors. And but it's difficult. As you say, sometimes they're not trusted. We're also short of doctors. Um, we need more doctors, and in certain cases, it takes a long time to get an appointment, which is a recent development. Um, I think, as you pointed out, Medicaid is a wonderful um, system that all the poor should have access to. But it's sometimes getting an appointment can be just the barrier that prevents them from getting the care that they need. Um, we don't have enough doctors, and that needs to be addressed.
And why is that, do you think?
For a long time, um, we felt that there were probably too many doctors, and we shouldn't organize more training programs. And that was a mistake. And we're beginning to realize it's a mistake. A lot of the countries that are socialized have imported their doctors.
Mhm.
We may have to import more than we do. Um, the barriers are considerable for people who haven't trained in the United States. But maybe we should encourage that. The other thing is, I have very sort of different views on that because I think the medical education is so expensive that we should make medical education free and just ask all those who profit from this to spend 2 years in primary care. I think it would take care of the problem.
Great
We
idea.
need more primary care doctors. And I remember during the Vietnam War, my husband was drafted, and we had to spend 2 years in the Army, and it wasn't such a bad experience. So giving up 2 years for something you love in exchange for getting a free education, I think would be a solution. But of course, that's rather drastic. And we need to look at other solutions, including maybe importing more doctors.
What about IVF. You've talked about, and I want to be sure I don't skip over it and go on to something else. You talked about the shortage of gynecologists in general, and endocrinologists who deal with other subjects. But what about that? I mean, if that is something that means the world to you to try to have a baby, what are your chances of finding a doctor like you who literally knows how to make it work?
Mm. Well, I actually don't do IVF. I did infertility before IVF came about. And now that all these big centers have evolved, which do this kind of thing more efficiently than I do. But IVF is very expensive. And it's, as I tell my patients, if you end up in IVF, it's financially and emotionally draining. And you have to be willing to go that route. Now, fortunately, certain states mandate that IVF be covered by insurance. So you've got a few chances of getting it covered, but it's a big step. And I think, you know, uh, not everybody can go that route, or not everybody wants to go that route. And there are probably simpler areas that could be improved to give patients better treatment with infertility. As an example, there's a syndrome called the polycystic ovarian syndrome. It occurs in about 20% of our population, so it's not rare. And it's associated with being overweight, having too much body hair, and having acne, and it's a recognizable syndrome. Well, those patients end up in IVF almost 90% of the time when they don't need to be in IVF. They can be treated without IVF.
Hmm.
So in some ways, doctors are pushing towards the higher income areas of treatment when they may not be necessary. And it's back to the same thing. I mean, if you make more money doing one kind of thing, that's what you're going to do. And it's unfortunate.
And it certainly is unfortunate with lower income women because there isn't a lot of money to be made from the government or from the state governments, I think, probably treating the people who are on Medicaid. Um, you know.
Yeah, absolutely. I don't think Medicaid pays for IVF, which is another problem.
Hmm.
Um,
Um, some of the schools here are offering free education, but
yeah.
that's like a drop in the bucket, right?
Right. Well, New York City has two medical schools which give completely free
Yeah.
education, including NYU and I think it's Montefiore. And Columbia guarantees that you're not going to graduate with debt. So if you can afford to pay, you pay, and if you can't afford it, or you have limited income, they will scale back the tuition. So things are improving. But, when you consider that in Europe, to become a doctor, it's a few $1,000s a year. And here they're paying 70,000 a year. So we've got a long way to go. And if we want more doctors, we have to improve that situation, um, because it's a difficult situation for bright people to decide whether they're going to go into more debt to become a doctor and spend so many years in training. And I think at this point, the doctors are very undervalued. So it's a problem that's just getting worse.
Going back to obesity for a minute, I just remembered something I read um, with the use of the weight loss pills that some women who could not get pregnant all of a sudden are finding themselves
Yeah,
pregnant, which was like, whoa, and all they did was lose the weight.
right, right. Well, the polycystic ovarian syndrome that I just talked about, if you can get people to lose weight, they have a problem with their weight, which is related to the insulin resistance that they tend to have. if they lose weight, they can become pregnant. And I think that's what we're seeing are probably people who have more insulin. If you're obese, you're going to have more insulin circulating. And if you can lower that, it will have signals to the ovary which allow it to ovulate and women can become pregnant. So we're learning things.
Yeah.
We're still learning.
Yeah, I guess it's a slow process, but if you're a woman in the middle, of your years, and you have such a limit on the years that you can be pregnant, it's probably really difficult. We don't, they don't want to wait while the doctors learn. They want it now,
Yeah.
obviously.
Well, we've made a lot of progress in infertility. I mean, I think if anybody really wants to have a baby, one way or another, they can have a baby. It's a good idea not to wait too long. And some people think, oh, well, I can always wait till I'm 40. Well, that's not true. I mean, the system ages much more quickly than the rest of our system. And there is a biological clock that women have to pay attention to. Um, but for
One
some
is
women, finding Mr. Wonderful is hard enough. So
I'm also thinking that biological clock is based on how long people used to live. If you go back to prehistoric times and the times that biblical times, you died somewhere between 30 and 40 if you were an average person, male or female.
yeah, it's true. Even when I was young, there was sort of a feeling you should have your first baby before you're 30. And you don't hear that anymore. Because in those days we didn't have IVF and we didn't have all the issues of treatment that we have now. Um, but yeah, I mean, things, in 1977, Rosalind Yallow got the Nobel Prize. She was the first American-born woman to get a Nobel Prize and the second woman to get a Nobel Prize. And she discovered tiny amounts, uh, a way to measure tiny amounts of hormones in the blood. And it changed everything. We learned about the menstrual cycle. We learned about how uh, people ovulate. We learned about contraception. It just changed everything. And interestingly, that system has been used to measure all kinds of things, drugs in the blood and tiny amounts of all the hormones. And it really changed the face of medicine, the way we treat people. But one of the things that happened is with our understanding of the menstrual cycle, there was a big improvement in understanding how to treat infertility.
Huh.
And I was part of that um, measure in that I worked for somebody at Columbia who was very interested in what we called induction of ovulation, which is making the ovaries produce an egg. And there were new fertility drugs on the market then that very few people used. In fact, the first drugs were made from Italy, and they came from um, convents where they collected the urine and refined the urine to get these hormones, FSH and LH, that the pituitary and the brain usually make. And they could directly make the ovaries work with these drugs. So it was very, very important in terms of treating infertility. And since then, we've used the drugs to prepare women for IVF, to give multiple ovulations. We use them for women who are being treated for cancer, who want to freeze their eggs. So there have
The
been a lot
same
of stuff.
drugs, the same as the original ones that
No, now they're made by drug companies. They've been refined and made by
Oh,
drug
yeah, by
companies.
drug companies, but I mean basically the same makeup of the drug.
Yeah, and they're FSH and LH. That's all they are. And when women become menopausal, they secrete a lot of these hormones, and as a result, you can isolate them in the urine. Now they've learned how to make them. They're simple proteins, and they're not difficult to make. And for a while, actually, when I was using it, it was more difficult to use the pharmaceutical products than to use the original products that were made from the urine because there was a ratio of the two hormones that were important that we didn't realize. But now that's been straightened out, and people are used to using the right ratios. But infertility is made big strides, um, but there's still more things to go. I mean, there was in the 70s and 80s and 60s, there was such an interest in contraception that we focused on women. And we know a lot more about fertility in women as a result than we know about men.
Uh-huh.
Yeah. And as a result, the men have really trained the understanding of how to treat infertility in men has really trailed way behind the issue in women. And that's beginning to change, but we have a long way to go because the easiest way to treat infertility in men is to do IVF, which just is a mechanical solution, really.
Yeah. Well, that's fascinating. I tend not, to like, I guess I suppose most women, I tend to focus on me
Yeah.
and my kind and not the men. Well, let me move back to menopause. Um, and, I think all of us who have been through it are still saying, why do we still have to go through it? Why isn't there a pill that will just kill it? You know, let it be over. Um, you talk about there not being enough doctors who can deal with it. Um, and I think a lot of people think, well, that's just it. Isn't it just something you just have to live through? Why do you have to go to a doctor when there really isn't much help anyhow?
Well, that's a big problem. As I mentioned, the doctors who treat menopause have to get extra training after they finish their training. And it's not well reimbursed. And as a result, it really is a small number of doctors. Now, there is the North American Menopause Society, which provides training and provides a certification. So you can go to their website and find doctors of different areas in the United States, but it's still a small number. And it's a big problem. I mean, I read somewhere, I think 10 years ago, that somebody turns 50 every 10 seconds.
Oh, wow.
Yeah, I know. And we're an aging population. That was during the time, I guess, baby boomers were turning 50.
Hmm.
But there are a large number of women still that need treatment. And it can be life-changing because at 50, a lot of women are at the height of their career. They can't just spend all night with night sweats and all day with hot flashes and be effective. And there have been a number of studies, including one that I did, which shows that more women retire at 50 than any other age.
Huh.
And I think it's related to some of the hormonal changes that are go untreated. Um, so why are we still having this problem? And it has to do with economics. It has to do with lack of training, and it has to do with also with a lack of interest in this time of transition, which is so important. Um, I saw a patient recently who was having terrible migraines, terrible, so that she was on three different drugs. and had been to see every neurologist specialist in this area. And she was obviously in perimenopause, which is the time when there are huge fluctuations in hormones. And the migraine is well recognized as being a problem at this time. And no one had thought to suggest treatment for her menopause. Now, that's really just astounding. Um, and it's sort of sad, really, because I think she'd seen a lot of distinguished people. Um, the other situation that comes up is depression. Depression can occur for the first time out of the blue for women at menopause. And the women feel that they're not getting the proper attention when they're only treated with antidepressants, because although some of them do need antidepressants, it does help to give them treatment for their menopausal symptoms as well. So you really need a combination of the two. And my son, I have a son who's a psychiatrist. He said, we get no training in this area at all.
Mm.
Um, but he's been impressed. I mean, he now, asks women, are you having hot flashes and night sweats? And when was your last period? Which is not something that psychiatrists generally do. So things are beginning to focus on that area, but and there are psychiatrists interested in that. There have been some very good studies from Harvard which have looked at this, but it's not permeated into the mainstream. And the problem we have in medicine is that for things to permeate the mainstream, it takes about 30 years.
Oh,
That's a long time.
gotta be dead.
Yeah, I know. I know. And the other thing that happened with menopause is the Women's Health Initiative, which taught us some things, mainly that we shouldn't start hormones in women who are older because there was an increased incidence of heart attacks and some increased incidence of breast cancer, but it was very small, very tiny. But as a result, so many women stopped their hormones. And, since then, we've now learned that if you take hormones at the right time, when you're going through menopause, it doesn't cause all these problems. And the breast cancer is a very small issue. It occurs in 8 per 10,000, much less than 1% after 5 years of use. So I tell my patients, who are worried about breast cancer, we can think about giving you treatment 2 to 5 years. You don't have to think about that further. We'll decide at the time whether you still need treatment.
Typically, how
But,
long does menopause actually last? I mean, is there a typical time?
well, that's a good question because there have been a number of studies recently um, on that very issue, and perimenopause lasts 2 to 7 years. That's a long time.
Yes.
It's a long time to feel miserable. And in terms of menopausal symptoms, when your periods stop and you no longer make estrogens, which is in the postmenopause, 11 to 15% can continue to have symptoms for the rest of their lives. So that's a problem. And, I see a number of patients who are in Medicare, and Medicare won't pay for hormones anymore. They
Hmm.
don't think that, yeah. So if they're in that small percentage that need them, it's very difficult for them. And they either have to pay for their prescriptions or go to a Canadian website and get the drugs from there. So it can be a lifelong problem for a small number, and it's a big problem.
I wanted to know more about the hormones because there was a time before that study came out when, I mean, that's basically what everybody was taking who knew anything about it or could get to a doctor. Um, what if you don't do hormones, if you're still afraid even now, what else is there?
Well, there are a number of medications that can help the symptoms. And one is antidepressants will decrease the number of hot flashes. But you have to remember that menopause is not just hot flashes, it's a whole symptom complex. There are mood changes, there are body aches, there are sleep problems, and some people get arthritic-like pains. Um, some people get terrible anxiety,
Mm.
even anxiety, which sends them to the emergency room
Mm.
with palpitations. So they get $1 million workup for heart disease, and no one thinks about menopause, which it can be in women at the right age who are suffering from these symptoms. So treatment with antidepressants can help. Um, there are there's one herb that I use which can help, but it doesn't help in severe problems. With severe problems, in general, I'm not a believer in the herbs because although there's a placebo effect, when you start using them, these patients go back to having problems after a month or so.
Mm.
Um, then there is a new drug which can help specifically the hot flashes. But again, it's very hard to get it approved by the insurance because it's new. And what it does is it it affects the area in the brain which is called the hypothalamus. It's at the base of the brain, and there are a lot of neurons there, including something called the Candy neuron, spelled KNDY. And that has been known to become very overactive without estrogen.
Mm.
With the lack of estrogen, it becomes very overactive. It initiates hot flashes and even sleep problems. And they found a drug that actually blocks that overactivity. Even though it's not estrogen, it's not hormonal. It can be used in women who have can't take hormones because not everybody can. So that's a breakthrough. But again, it's very hard to get insurance to approve it. One of my patients recently said, well, I have to pay $500 a month and I can't afford that.
Whoa.
And yeah, so you have to advocate for them and see if um, you can get the insurance company to pay for it. Um, and that's about it. It's hormones, it's antidepressants, it's this new drug. It's advertised all over the place. It's called Veoza.
Mm.
Um, and there are some antidepressants that are particularly more effective than others. But those are the issues. And then there are lifestyle issues that can help. Exercise, breathing, yoga, it can help. But in patients who are really sick, who have big problems, it's not going to be the answer. So
And men don't go through anything. I mean, we joke about it, but men don't go through anything like we do.
no, they have a progressive depression in testosterone and have issues related to that. But in fact, if you treat men with prostate cancer with some of the hormone blocking drugs that they take, they can get terrible hot flashes.
Huh.
Yeah, terrible. But otherwise, they don't get any of the things that we see in women. Um, you know, the problem in women is very acute. And as I said, it occurs in women at a very important time of their lives. They can be, at the height of their career, they can have adolescent children that are causing all kinds of problems. And it's a game changer for them. It's a terrible problem. I often used to tell my patients, if you want to lose your job, your sanity, and your partner, don't take the hormones.
Right.
So
in kind of wrapping it up then, basically, where do we go from here? I get the sense, because most of the advances in women's health, which I see particularly, from abortion and from the standpoint of abortion becoming legal and now being taken away, and then the issues of hormones, which for a long time we just thought we took indiscriminately in a sense. Where do we go from here? I mean, if we've taken a couple of steps backward with the abortion issue in terms of controlling our own bodies, and improving the overall health of women, whatever their period is, whether they're having children or they're beyond it, you know, it doesn't seem like it seems so many women are becoming doctors now. And this is where it should stem from. And yet it doesn't seem like an overwhelming issue, women's health in general.
Yeah, well, there's a lot of interest in women's health, regardless. And yes, there are 50% of the doctors that are graduated now are women. And in fact, there are more women doctors on hormones than any other group because they understand the statistics. They're not scared.
Yeah.
Because they understand the issue of understanding the statistics, which have been overblown in the press, is very difficult for the general public. And I used to have analogies that I used to give patients to try to convince them. But, if they have a mother who died of breast cancer or they have a lot of breast cancer in their family, they're frightened. And I understand that. Yeah, why aren't we more aggressive about improving these issues? Well, I think women can make a difference if they get together and decide they're going to change things. And I think both doctors and patients need to get together. And I think to accomplish what we want, it has to be done at a leadership level. And, women vote. And if they get together and vote appropriately, it should make a difference eventually. Our country is very troubled right now. And we failed to elect a woman for president.
Yeah.
Yeah, but I think that's eventually going to change. And we have a lot of smart, educated women in the United States. And I think eventually we'll get it done.
Well, that's a good, hopeful, optimistic message to wrap it all up on. And I think we need a little optimism right now. So
Yeah.
thank you. Thank you, Michelle. Thanks so much for spending the time and doing the podcast and
Oh,
telling us
that's a
so
pleasure.
much.
Pleasure, Stephanie. Thank you.
Dr. Michelle P. Warren is a distinguished New York physician and specializes in both endocrinology and gynecology. She spent her lifetime focused on women's health issues. And in 1997, Dr. Warren founded and remains the medical director of the Center for Menopause, Hormonal Disorders, and Women's Health at Columbia University Medical Center, where she is the Wyeth Professor Emeritus of Obstetrics, Gynecology, and Medicine. Now, I'm working on several possibilities for the next episode, which would be episode 30, but nothing's firm yet. And so what I'll do is I'll update you at the bottom of my podcast page just as soon as I know exactly what we're doing. Look for episode 30 to drop on the third Tuesday of February, since I schedule one new podcast a month. I'd really appreciate it if you would subscribe and share. We're on Apple, YouTube Music, Spotify, TuneIn, Amazon Music, iHeart, Podchaser, and my host platform, the Podbeam app. The video version is, of course, on YouTube. Show notes and links on my website, www.stephanieshelton.com/conversations. I'm Stephanie Shelton. Take care of yourself and all those you love, and I'll see you next time. Conversations on Health, How We Get There is produced and edited by Frank Harold. Research assistance from Dr. Richard Saltman, Professor Emeritus of Health Policy and Management, Rollins School of Public Health at Emory University in Atlanta.